There we go. So hello everybody, and thank you for joining us for tonight's seminar series on cachexia in cancer. My name's Nicola. I'm a research fellow in the Marie Curie Palliative Care Research Department at UCL, and I'm going to be hosting tonight's session. So just a little bit of housekeeping before we start. Firstly, I just wanted to mention that this session is going to be recorded. So we're going to upload it to the website for people who are unable to join us tonight so they can watch it later on. Secondly, if you have any questions about the presentation, please feel free to type them into the chat box, and after the presentation I'll try and read out as many as I can, or as many as we have time for. If you would prefer to ask the question yourself, please put that in the chat box as well, and I'll ask you to unmute, or I think there's a little icon where you can raise your hand. I think it's always a bit nicer if you can ask your own question. Again, I am sorry if we don't have time for all of them, but Barry has said that you can contact him afterwards to follow up on any questions. Thirdly, there are subtitles available for this seminar. You can turn this function on should you require it via the live transcriptions box at the bottom of the screen. And finally, can you please keep your cameras off and your microphones on mute throughout the presentation. Once the presentation's over though, I'll invite you to turn your cameras on and unmute if you want to, as it might be nice for Barry to see us all. Oh, sorry, enable. It gives me great pleasure now to introduce you to our guest speaker, Dr. Barry Laird. Dr. Laird is a consultant in palliative medicine at the Edinburgh Cancer Centre and St Columba's Hospice. He's also a reader and associate professor in palliative medicine at the University of Edinburgh. He's part of the Edinburgh Palliative and Supportive Care Group, the EPAS, which is led by Professor Marie Fallon at the Institute of Genetics and Molecular Medicine. Following his mentorship from the late Professor Ken Fiernan, Dr. Laird continues to develop research in cancer cachexia. He's passionate about transforming the landscape of this through improved understanding of the genesis, mechanisms and treatment via an evidence-based translational research programme from basic science to clinical trials. This evening, Barry's going to discuss some of the research with you, with his presentation titled The Changing Landscape of Cancer Cachexia, from Nutrition to Metabolic Syndrome. So Barry, I will now stop sharing my screen, and if you would like to share yours.
Perfect. Thanks, Nicola. Let me just try to get the screen up. So
are you going out that way? Would you just get my iPad?
Oh,
then I have 3 screens.
Who's sorry, just to remind everyone to put on mute, please.
Right, I'm just checking here. See my screen. So can you see my screen, Nicola? Okay.
Yes, we can see it, Barry.
Perfect. Paddy, thanks. Can you see what can you see
Yes.
the presenter view or the correct view from your point of view?
No, we
yes.
can see the presenter view at the moment, I think.
So I'll swap it over. Now you can see the...
That's the correct view, yeah.
That's the correct view. Super. It's always tricky when using 2 screens. Right.
That's perfect.
Right, perfect. Listen, so firstly, apologies for being very slightly late tonight, and a big thank you to Nicola, Paddy and the whole team for the honour of giving this this lecture tonight. Thanks everyone for attending at the end of a long day to listen to me talk about cachexia for an hour. I don't know if I feel sorry for you or I'm quite flattered. I'll say with flattered. So I'm a consultant in palliative medicine based in Edinburgh. I work as a consultant in a hospice and in a cancer centre, and I also work in an academic capacity in this building here, which is the Institute of Genetics and Cancer, which is based on the Western General Hospital campus in Edinburgh. That's next to the Cancer Centre. It's quite nice having a research facility actually at the Cancer Centre, because it allows for a lot of sort of cross-pollination of research and clinical work. I would just like to say that, you know, a lot of the work we present tonight is only being made possible due to a lot of funding we've had from these different people. And by no way, shape or form am I claiming tonight that this work is all mine and mine alone. I'm very fortunate to work with a large team of people who are excellent colleagues, collaborators and scientists and clinicians. So, kindly present this work on behalf of us all. So, cancer cachexia, let's try to put it in some form of historical context here. This is University of Edinburgh, founded in 1582, so 500 years ago. But we'd have to go back to 2,000 years before that, to about 400 BC, when Hippocrates first described the condition of cancer cachexia. Kakos and hexia meaning bad condition. So this is a condition that's really been around for 2,500 years. But as we practice palliative and supportive medicine today, we actually have no treatment available for cancer cachexia. So to me, that is both a challenge and an opportunity to try and change this in some way, shape, or form. Now, I've titled the lecture "The Changing Landscape of Cancer Cachexia from a Nutritional to a Metabolic Syndrome." And what we often think about when we think about cancer cachexia is people losing weight. That's what we see. That's what people tell us. But there's actually probably a lot more going on to it than just simply losing weight. Now, I always like to put this slide up. The chap in the top corner with the glasses and the beard was Rudolf Virchow, so of Virchow's nodes. And he was a pathologist and a German physician. And he was a man that described cell theory, that the origin of cells was pre-existing cells that occurred. And he really was one of the first people to describe the role of inflammation being sort of a precursor to disease. Now, what I find quite interesting about this in the relationship to Edinburgh is that he was very much influenced by the chap in the bottom of the screen, who was called John Goodsir. And Rudolf Virchow actually dedicated his PhD thesis to John Goodsir of Edinburgh University, which is quite a nice thing to do. So there's a sort of strong history of the inflammation and inflammation research in Edinburgh going on, and we have a large institution specifically dedicated to that. So when Virchow first described, inflammatory process and how it led to cancer, we know nowadays cancer's come on a long way. And when we think about how we treat cancer, how we manage cancer at the moment, the current approach that we have in oncology is essentially two things. If any of you ever attend a cancer MDT, a multidisciplinary team meeting, you'll know that
having to have repeat swabs done, which is absolutely pointless. It's wasting resources for a start, and patients' time and energy.
I don't know if somebody's maybe could put themselves on mute, if that's okay. I can deal with hecklers if we need to, though, that's fine. So yeah, the current approach in oncology, stage the tumour. So when somebody presents with, for example, a cough, and they may have an X-ray done, and it turns out they may have a suspicion of lung cancer, eventually that patient's case will get to an MDT. And in that MDT, what we'll try to do is stage the tumour, work out, the radiological stage of that tumour. Has it spread, the nodal stage or the metastatic stage, and then go into the deep pathology of that tumour, so we can try and tailor any treatment specific to the subtype of that tumour. We spend a lot of time staging the tumour. And then once we've staged the tumour, what we'll often do then is we treat the tumour. We try to treat the cancer. Now, in our MDTs, I'm sure they're not that different from the rest of the UK or internationally, we pay a lot less attention to staging the patient. What is the patient like? Now, we will often make an assessment of performance status, which we know can be a good marker of patients' prognosis, but also their ability to cope with systemic anti-cancer therapy. But we spend far less time staging the patient as we do staging the tumour. And then we go to an approach where we try to treat the tumour, but we don't do too much treatment around the patient. And that's something I'm going to come on to later on. So I do think that what we do a wee bit is a sort of an anatomy rules all concept here, where we think of symptoms almost a wee bit like handmaidens, and they're quite different. So somebody's got a tumour, we will treat that. And if they have symptoms, well, we'll try to treat that, or often myself and my colleagues in palliative medicine will be involved in trying to treat the symptoms that go along with cancer. They're often seen as two distinct things, but we need to move away from that concept. Now, in terms of the inflammatory response, two guys, Hanahan and Weinberg, first sort of published in 2007 their theory of sort of cancer and how it develops. This was updated by them again in 2012 and then again in 2021. And what they've said is you need certain things for cancer to happen. Certain things for cancer to happen. And this includes, avoiding immune destruction, resisting the automatic sort of cell death that occurs, the cells evading the natural systems in the body which cause stop tumours growing. But key to this is what we call tumour promoting inflammation, or oncoinflammation. And this sort of argued now is this oncoinflammation, this inflammatory response, being critical in the development of a tumour, but also maintenance of the cancer state. So in cancer biology, inflammation is widely accepted as being one of the key components in development of a tumour. And this was a study we did in Scotland almost 20 years ago now, when we looked at C-reactive proteins. So for those who don't know, C-reactive protein is a measure of, if you like, the inflammatory response going on in the body. It's a sort of surrogate of a cytokine called interleukin-6. And when CRP goes up, it means you're inflamed. If CRP is down, it means you're not inflamed. And this was how we looked at how C-reactive protein changed over time. And we looked at two groups of people. Now, in terms of an inflammatory insult, there's two things for comparison here. You've got elective surgery here, and you'll see here at time point, so this is time point 0, day 1 here, you'll see an elective surgery here. Just at the point of surgery, then the body mounts a huge immune response, which kicks in really about sort of day 2. The body becomes inflamed because undergoing a major insult. But then after, by about 2 weeks, that's died down again. But comparing that to an inoperable non-small cell lung cancer, at the early stages, CR-reactive proteins obviously also inflamed, also raised, sorry, and then it can continue to rise throughout. So there's not this sort of refractory phase where it gets better again. It continues to be at quite a high level. So this is what's going on in a lot of our patients with cancer. Their CRP is actually quite high, and we're not able to normalize it. Now, that CRP is just one measure, but if we think of how the liver works, the liver produces lots of these different cytochromes, which have multiple effects in our patients, including increasing drug toxicities, decreased pharmacological effects of therapies such as chemotherapy, immunotherapy, and also increased adverse drug reactions. So we know that it's quite bad for how our chemotherapy or immunotherapy drugs are given. It's the beginning, as I say, the beginning of the bad journey that occurs in a lot of our patients. We've tried to quantify this in a way that's a bit maybe more clinically meaningful. So colleague of mine, Professor Don McMillan in Glasgow, developed he wanted that there was a very famous score in Glasgow, the Glasgow Coma Scale, which is well known, and he thought he could do something very similar. So he developed what's called the Glasgow Prognostic Score, where he combined two parameters, C-reactive protein and albumin. Now, I've already told you that C-reactive protein is a measure of the inflammatory response. It's a positive marker of inflammation. As you get inflamed, CRP goes up. But albumin, we also have to think of albumin as a nutritional marker. And it is to some extent, but it's also a negative marker of the inflammatory response. So as you become more inflamed, your albumin goes down actually. So he developed this score ranging from a score of 0, so a low CRP, and your albumin, it almost doesn't matter what it is depending on, so your CRP is low, that's fine. Score of 0, but if your CRP is raised and your albumin is normal, you have a score of 1. If your CRP is raised and your albumin's less than 35, that's a score of 2. And essentially, a score of 0 is good, a score of 2 is bad. It's a quite simple score. And we thought we could use this to try and see how this inflammation that we know is a big thing in cancer development, how does it actually impact on people with cancer? Well, we did, one of the first sort of bigger bits of work we did was we looked at how it relates to symptoms. Now, we looked at patient-reported outcome measures using a sort of well-respected questionnaire called the URPC Quality of Life questionnaire. And what we looked at was sort of common symptoms we see amongst people, pain, appetite loss, breathlessness, fatigue, etc. And we wanted to see what happened to those symptoms in people who were inflamed versus those who were not inflamed. So just about across all categories, this is CRP less than 10, not inflamed, CRP greater than 10 inflamed. If you were inflamed, your symptoms were a bit worse. And this was in about 1,500 patients across a European cohort. So we knew that inflammation, from this we took the inflammation bad for cancer development, but also bad in how it made patients feel, I guess. Now, we also wanted to see if that made a difference in terms of prognosis. And Professor Stone, who's on the call, is a leader in the world of prognosis as well. And we looked at this area, and others have too. And we showed that essentially this Glasgow prognostic score predicts symptoms, but also predicts survival to some extent as well. So if you were inflamed, you felt worse, and you did worse, basically. Now, to sort of convince oncologists that a simple blood test is enough to tell somebody how they're feeling or their prognosis is maybe a bit of a step. So we sort of looked back to this ECOG performance status, which is what's widely used in the clinic or the MDTs, where you go from a score of 0, so I'd hope we'd all be an ECOG score of 0, fully active, able to carry out all sort of activities of daily living, to an ECOG score of 4, where patients are sort of completely disabled. And we know that essentially, as people develop, up the grades to ECOG of 4, the prognosis gets less. So we thought, how can we try to bring this performance status and inflammatory score together? And we developed this sort of small ready reckoner of inflammation using the Glasgow score here, 0 to 2, and performance status. And this was survival at 3 months in patients with advanced cancer. And what we essentially showed was that if you were not inflamed and you had a good performance status, your survival at 3 months was pretty good. Sort of 88% of people were alive at 3 months. Conversely, here, if your inflammation level was high and your performance status was poor, your survival was pretty low. So what was interesting about this is both ECOG worked well on its own, GPS worked well on its own, and the M, is a modified Glasgow prognostic score. That's what the M means, just I didn't mention that earlier. But they both work, so the GPS works on its own, but together they're a bit synergistic. So together they're sort of greater than the sum of their individual parts. We thought that was quite interesting, and that's been sort of replicated now in a large number of studies. This combination of ECOG, which is function, and GPS, which is inflammation, working together. And we published a larger piece of work here looking at quality of life, again showing that essentially you can have quite a good performance status, but if you're inflamed, your quality of life is deteriorated. So we took this really forward to think, well, this Glasgow prognostic score, and there are other inflammatory measures available that you could be using, but essentially inflammation would seem to predict symptoms, we seem to predict survival, we seem to predict quality of life and potentially treatment efficacy. But how does it relate to cancer cachexia? So some of you may be aware of this definition, some may not be, but just as a brief summary, this was published back in 2011 in the Lancet Oncology, led by my late colleague, Professor Ken Fearon. And what they wanted to do here was not to say this is what it is, this is what cachexia is. What they wanted to do was to say all these people in a room got together and said, this is what we think it is. And this, at this moment in time, 11 years ago, this is our working definition that's to be put forward, tested, potentially supported, potentially questioned. But they described cancer cachexia as a multifactorial syndrome characterized by an ongoing muscle loss, with or without fat loss. So that's a key point here, because what they're saying for the first time, it's not just about losing weight, it's losing muscle, and you can have somebody who can lose muscle and not lose fat that could have cancer cachexia. So that's the first critical point of this. The second critical point is it cannot be fully reversed by nutritional support. So just giving people who are losing weight with cancer extra nutrition is not sufficient to stop it. Okay, it's not sufficient to stop it. More gas in the tank is not the solution here. And the final bit is it leads to a progressive functional impairment. So people are losing muscle, it's not reversed by nutrition, and it makes them weaker. And the pathophysiology is characterized by negative protein and energy balance. So people are essentially using up more energy and protein than they're taking in. And a combination of reduced intake and abnormal metabolism. The way I've always thought about this is a bit like your car. You turn your car on and you're not actually moving, but the engine's running, and your rev counter will sit at 1,000 RPM. It's a bit like the body, over revving at this point, sitting at 2,000 or 3,000. It's just burning up more fuel than it needs to at this sort of point. So this was set out, and then people tried to sort of test it again. So a group, again, colleagues and collaborators in Canada thought, let's look at weight loss and BMI. People understand that losing weight's bad. People understand that if you've got a low BMI is bad. So let's look at that. And this was a huge study in 8,000 people with cancer. And they developed this score of BMI weight loss. So BMI 28, so just slightly overweight, going to a BMI of 20, and a weight loss of 2.5% up to 15%. And they sort of developed, again, this sort of ready reckoner looking at survival. And this is survival in months overall. So if you're slightly overweight and you've lost minimal weight, you're sort of, across multiple cancers, your survival is about 21 months. But if you've lost a lot of weight and you've got a low BMI, your survival is much less. So they sort of postulated here that this weight, your combination of your weight loss and your BMI really predicted your outcome, really predicted your survival. We were interested in this really because we thought, well, that's slightly contrary to what the sort of cachexia classification definition said. It was saying it's muscle, really. It's not too much about weight, and when weight is a lot of components in your body. So we then tried to take this a wee bit apart and looked at the relationship between inflammation, performance status, and weight loss grade in different parameters of cancer cachexia. And essentially what we showed is as your function, as your ECOG performance status worsened, you had less muscle and less function ability, less able to do things. And that's quite consistent. But interestingly, high BMI and high degree of weight loss wasn't really associated with muscle. It was just really associated with a loss in fat. we're saying, well, it's probably important to some extent, but if what it's actually measuring this system is loss of fat, not necessarily loss of muscle. And then again, we took it a bit further, because we thought, people who have lost minimal levels of weight, does that really matter too much? Does that make a huge difference to people? And again, what we showed was that in patients who had a good performance status and a good BMI weight loss rate, they hadn't lost much weight, the BMI was okay, the level of inflammation effectively stratified the survival between 11 months and 7.5 months. So what we're trying to say here is that we think that inflammation is actually quite a key aspect of this. It's potentially more sensitive than some of these other parameters that we're using when we talk about weight loss and we talk about function. And then we did, my colleague Ross Fallon in Glasgow led this, where he did a systematic review of trials. These are trials of systemic anti-cancer therapies across multiple tumor types in advanced inoperable cancer. So inoperable tumors, how did inflammation affect outcomes? And this is a very nice, sort of forest plot he did, and it's essentially showing that in these studies, the inflammatory status of the host or the inflammatory status of the patient predicted outcomes. So how inflamed you were actually predicted how effective the treatment was or not. Now, based on a lot of different work, some tumor groups, so for example, pancreatic cancer, are saying in their mandatory data set for clinical trials in cancer cachexia, we now must record the inflammatory status of the host, and also stratify treatments based on inflammation status, because a lot of trials haven't been doing this. So in terms of defining cancer cachexia, well, I think there's really two key components here. There's function, and that's a crude measure, I guess, of your muscle, which is, you can use sort of an ECOG performance status score or something a bit more sophisticated, which we'll come to. And you can measure inflammation using the GPS, neutrophil count, or neutrophil lymphocyte ratio. And my colleagues sort of produced this sort of slide saying that essentially, if you've got a GPS score of 0, then you're probably okay, but we might give you some attention to weight. If you've got a GPS score of 1, you're in a sort of early cachexia phase, and you need to start treatment for that. And if you've got a GPS of 2, you've got refractory cachexia, and there's probably not a lot that's going to make a massive difference. He also sort of says, well, in these patients, if you've got somebody with a bad cancer, so let's say a lung cancer or a pancreatic cancer, if you've got somebody with a bad cancer who's got a GPS score of 0, you could probably throw the kitchen sink at them in terms of cancer therapies. If you're somebody who's got a Glasgow score of 1, he argues that you should still give them cancer therapy, but you need to treat the cachexia alongside that. And he argued, I think, somewhat controversially, that if you've got a GPS of 2, really treatment should be focused on dietary interventions and anti-inflammatories, potentially not having systemic therapies. That's just a viewpoint. Is for debate and discussion and to be tested in the future. So cachexia definitions have moved on a bit. And we've gone from this sort of consensus definition to trying to test it. So the Fallon criteria was weight loss of greater than 5%, or weight loss greater than 2% and a low BMI, or weight loss greater than 2% and sarcopenia, so that's loss of lean mass. A guy called William Evans in the US said, no, I think inflammation needs to be part of this definition. It's important and it needs to be there. It needs to be in the room as we discuss cachexia. So he argued, no, you needed to have weight loss or a low BMI and some degree of either a raised CRP, low albumin, or sort of fatigue or decreased muscle strength. And when they sort of put all these definitions head to head, maybe can't see it terribly well here, but essentially This is the Fallon criteria, looking at a large independent group of patients. And you can see the difference between cachexia and no cachexia. The survival curves, they do separate, but they're not too far apart. But using the Evans definition, there's quite a marked difference here. So the sort of conclusions of this paper were that you know, you need to include these additional factors such as inflammation to really get the true measure of cancer cachexia. So that message is slowly, that's sinking in now. The ESPEN guidelines, which is probably, I think, you know, the better guidelines on cancer cachexia and clinical nutrition at the moment, have taken us even further. So what they're saying is that if you get a patient with malnutrition or undernutrition, there are various different categories. And if you've got disease-related malnutrition with inflammation, if it's acute, then that's one thing. But if it's chronic disease-related inflammation, with chronic disease-related malnutrition with inflammation, it's essentially cancer cachexia. So they're saying if you've got malnutrition and you've got systemic inflammation, that's cancer cachexia. So we've taken that definition 11 years ago and moved it forward, as was always meant to. And you know, half the battle in any researching anything is trying to define it. And I think cachexia, we've come a long way in establishing that the role of the inflammatory response is right up there with loss of function and loss of lean mass. So how are we going to treat cancer cachexia? That's what we want to know. What are we going to do? How are we going to approach this phenomenon? Well, I said earlier that what we do often in oncology is we stage the tumor and we treat the tumor. But I think we can do it better than that. So what we need to be doing is we stage the tumor. We're actually going to stage the host. We're going to, and the host, by the host I mean the patient here. We're going to stage the patient. Let's look at their performance status, but let's look at their inflammatory status too. And as we're going to treat the tumor, we're going to treat the host or treat the patient. So we want to try and optimize their nutrition, optimize their function, and target this systemic inflammatory response. And this is a lot of the work we're trying to do now, is staging the host and treating the host. Now, it's now in the ESPEN guidelines, what they're saying, so this is a big sort of nutrition guidelines that I was fortunate to be part of, is that when we talk about improving nutritional care for people with cancer, what we want to do is screen all patients with cancer for nutritional risk early in the course of their care, regardless of their body mass index and their weight history. So somebody coming in to see in clinic who's overweight, it doesn't matter. You've got to still screen the nutritional status. And what they're also advocating here is increased nutritional assessment to include anorexia, their body composition, how much weight, how much muscle, how much fat they have, but also inflammatory biomarkers. And they said, you know, using, for example, the Glasgow score or some form of inflammation is we should be doing that in terms of our screening of patients with cancer cachexia. So we've screened them. We're going to try and treat them now. Well, there are sort of, I guess, three sort of pillars of cachexia really. I say there's inflammation, this function, so physical activity or physical inactivity, and nutritional intake. And that presents often as patients not doing very much and complaining of having a poor appetite. So we would argue that if you know, cachexia is a multimodal syndrome with a complex genesis. If we're going to treat it optimally, we're going to try and treat all these different aspects if we can together to some extent. But in the systemic inflammatory response, it's got to be a bit of a critical component of that. So we've moved forward now with quite a lot of clinical trials in this area. So this is some of the trials we've got running in Edinburgh at the moment. I just thought it'd be interesting just to talk through a few of these with you. I've tried to sort of classify them into a sort of phenotyping trial, a basic trial, a basic plus, and targeted therapy. You know, in oncology nowadays, you know, where somebody's got a non-small cell lung cancer, we don't just, you know, throw a treatment at them and hope for the best. We try to work out what subtype of non-small cell lung cancer they've got and give them, you know, almost a precision medicine approach to that type of tumor. And in terms of cachexia, we've got various different programs running. The first thing we're doing is a large study called Revolution. Then we've got what I call basic, which is just get exercise and nutrition. We've got basic plus, exercise, nutrition, and inflammation. And then we've got some targeted approaches too. So, for example, a revolution study. So one of the challenges is there's not been a large prospective characterization of people with cachexia. We don't really know the natural evolution of it. So we're doing a study where we're trying to essentially phenotype clinically, radiologically, biologically, and also based on tumor treatment, what happens to people when they have a cancer diagnosis. And you know, we're running that study in Edinburgh in the cancer centre in one of the hospices in one of the major teaching hospitals, and we're about to open a couple other sites in Glasgow and Southampton as well. What we want to try and develop is a large biobank of data for people with advanced cancer that we plan to share with whoever would like to access it, a sort of cancer-specific version of the UK biobank, if you will. So that's one of our observational studies. We've then got I call it basic approach. I guess basic is you know, what happens if we give people who've got incurable cancer some exercise and some nutrition. Often trials in the past have given one or other, but to work best, you have to give people both exercise and nutrition. If you just give people food and you don't get them to exercise, they just get fat, they just gain fat, and we know that's not particularly helpful. If you just give people exercise but don't give them enough nutrition, it doesn't allow them to develop their muscles. So, you know, we think that giving exercise and nutrition together, we did this as called our energy trial, is a good approach. And this was a feasibility study, and so it wasn't designed to see if the trial was effective or not. It was just to see, could we do it? Can we give people with advanced cancer an exercise and dietary program to see if we can improve things for them? So feasibility study was positive. People did what we asked them to do. The study, we did some preliminary health economic analysis, which suggested actually doing this might be cost saving because it may prevent hospital admissions and less contact with healthcare professionals. And we also did an embedded qualitative study. Patients told us they liked doing this as well. They felt better on it. We're now moving from Energy, which was a phase 2 trial, if you like, to Energize, which is our phase 3. So that was basic. Let's go to basic plus. So I'm part of this Menic consortium, one of sort of the 4 leads in that, and we did a study called the Premenopause trial, where we did some basic plus. So we gave exercise, we gave nutrition, we gave anti-inflammatories as well. We gave patients ibuprofen to see if that helped, and we gave it alongside systemic anti-cancer therapies. So we wanted to see if we can provide a sort of standard of care along this. So these were our findings. Again, this was a feasibility trial. This was not designed to assess if it was efficacious or not, but what we showed was that if we gave people exercise, nutrition, anti-inflammatories alongside chemotherapy or immunotherapy, these are the 2 waterfall plots here. So this one is body weight. The red arm is the treatment arm, and the control arm is blue. So that's people didn't just get standard care. And what we saw here was that people who got the treatment arm, got exercise, got nutrition, got ibuprofen, they tended to gain some weight. But weight, it can be many things. It can be muscle, it can be fat. So we looked at muscle as well. And interestingly, these findings were mirrored in muscles. Patients were gaining weight, but they were gaining muscle too. So this was very encouraging. We thought actually this could be a good thing for people. So we've moved on from pre-Menic. We're now doing Menic. We're actually almost finished Menic. We have 1 patient to get. And if any of you have done clinical trials before, when you're getting a 200 patient study, that last patient seems to lose itself for many months. So we do 1 patient and then we're finished. And that's essentially building on our phase 2 trial, looking at this standard of care. And if it's positive, we're very much hopeful this standard of care of exercise, nutrition, and potentially anti-inflammatories could be given alongside some standard cancer care therapies at the moment. So we've made some progress here. There's been some commercial studies that have been done as well, and these are really interesting. There's a study was done called the Romano trials, and there was 2 large studies, Romano 1 and Romano 2, These were identical trials of a drug called anamorelin. Now, anamorelin is essentially a ghrelin agonist. Now, ghrelin is the hormone in your body that makes you feel hungry. So basically, this was a sort of a surrogate version of ghrelin. And 2 trials were done. The reason you do 2 trials is to get sort of FDA approval to license a drug. You need often 2 large studies in cancer. So this same trial was done looking at anamorelin for cancer cachexia in patients with non-small cell lung cancer, published in the Lancet Oncology in 2016. Now, one of the challenges we've had in cancer cachexia is trying to define it, which I highlighted earlier, but also trying to measure it. So how do we measure cancer cachexia? Well, often, certainly with pharma, we're guided by the regulators. What we want to do is get a drug which is going to be beneficial to patients, but ultimately to be licensed so that it can hopefully recoup some of the investment that's been made in it. So for this Romano study, what was defined as a positive endpoint was patients. We measured lean body mass. So lean body mass is essentially muscle, and they measured HGS. So HGS is hand grip strength, how much you can squeeze your hand. And it was sort of deemed that for the trial to be successful, comparing the drug versus a placebo, people had to improve muscle, so improve the lean mass, but they also had to improve their function. They had to have more muscle and were able to do more. Now, unfortunately, that trial was deemed a negative study, because whilst it seemed to make people gain lean mass muscle, it did not improve their hand grip strength. So by that point, it went for regulatory assessment to get licensed, and it was turned back because the hand grip strength was not improvement. So the regulator said it has to improve lean mass, improve muscle, and make people function more, and it didn't do that. So this was a thought. Everyone was very disappointed about this when it came out. This was a big disappointment. This was probably one of the few drugs coming up, going to phase 3 trials. We thought this could be something we have, and it was declined. But what's interesting is, if you look, what we're doing is giving people a drug that made them hungry, made them want to eat more. And what we thought was, right, if you eat more, you'll gain muscle and you'll be more active. Now, I know if I eat more, it doesn't make me gain muscle and become more active. I have to become more active anyway, and so it'll just make me gain fat. But then again, in the context of a clinical trial of 12 weeks, what we're saying is we're going to give these people with non-small cell lung cancer, right? So stage 3 or stage 4 non-small cell lung cancer, a drug which is going to make them hungry, and over 12 weeks, make them gain muscle and make them gain strength in their muscle as well. To me, that seems like quite a tall order. If you think about it this way, this is looking at what we call a relationship between muscle mass and function. People need to lose a lot of muscle before they suddenly start to deteriorate in their function. So we see this with patients. They can lose a lot of weight, lose a lot of muscle, but then it's at that latter end point they start to become less able to function in life. So that takes a long time for muscle to drop before function just plummets. And conversely, in people who are old or have comorbidities, they have to gain an awful lot of muscle for their function to then increase. So it's not a proportional relationship here between muscle and function. But yet, for the Romano trials, we're thinking, if we give this drug, are we going to make people get more muscle and more function? I think it's quite a hard ask to do. I think the other challenge with a study like this is that hand grip strength is not a very good measure. As people get older, it becomes less reliable. So I think it was quite a bad measure of function to choose. It was quite interesting in this Romano study, in those Romano studies in the paper. They said at the end, this is the penultimate paragraph, assessments of changes in lean body mass and hand grip strength within additional subgroups of interest, including by inflammatory status, were not done, but do represent areas of future research. They were saying, we didn't look at inflammation, but that might be something that'd be interesting to look at in the future. Now, around the same time as that was published, that negative study, Herbert Hurwitz had seen our Glasgow prognostic score, and he'd done a trial of ruxolitinib. So that's a JAK-STAT inhibitor. So that's an anti-inflammatory versus placebo in people with cancer, and it's shown essentially there was no difference in survival advantage. So given a trial of an anti-inflammatory versus a placebo, and it's shown no difference. Now, we had a discussion with them, and we thought, well, if you're going to give an anti-inflammatory to somebody, it's going to work best in somebody who's got inflammation. So they did this post hoc analysis. It wasn't powered to assess this. It was just what we call a post hoc analysis, a sort of extra analysis, if you like. But he looked at his outcomes over our different inflammation scores. So a Glasgow score of 0, so not inflamed, a score of 1, quite inflamed, a score of 2, quite badly inflamed, and essentially survival changed. So the drug was more effective in people who were inflamed, in other words. So, surprise, surprise, giving an anti-inflammatory to people who are inflamed, it worked better. If you go to the mechanisms of action of anomorelin, it's actually got quite a strong inflammatory process. It works in interleukin-6 and TNF-alpha, which are both fairly strong inflammatory markers in the body. So we approached Helson, who ran these trials, and said, we're interested in your data. So what we did was we did another analysis of the data, which we saw, I wonder what happens if we look at the responders based on their inflammatory status. So we're quite excited when we saw this. This was essentially all the patients in the study, and we looked at body weight, lean body mass, fat mass, hand grip strength, and what we call the FACT score, so functional assessment of Cachexia score, and fatigue. Now, across the scores of not inflamed up to inflamed, and essentially across most of the categories, there was sort of suggestion that actually the people who were inflamed did better on anomorelin. So, for example, if we look at lean body mass, it's an improvement here. We look at hand grip strength, much stronger in patients who are inflamed. Same with symptom scores as well. And this is not really that surprising because, as I said earlier, people who are more inflamed have more symptoms and do worse. But so we have to try and target these drugs in the right way to the right people. We have a bit of a habit, I think, in palliative and supportive care of sort of using a bit of a blunt tool here when taking some of the rules from oncology, where we try to give the right drug for the right patient at the right time is key. So it would suggest here that the inflammatory of the host actually influences efficacies of therapy. So can we sort of then target the inflammatory response to treat Cachexia? So a lot of potent immunotherapies out there at the moment. So one sort of key one in that is a thing called interleukin 1 alpha. So that's sort of upstream of interleukin 6, and it's a fairly potent inflammatory cytokine that is responsible for a lot of cachexic effects. Essentially, it causes a lot of gluconeogenesis, fever, causes muscle breakdown, causes fat breakdown, and it has central effects on appetite and all the things that sort of make you want to be hungry. So this is potentially a fairly big player in the whole sort of Cachexia arena. So we've got funding from the MRC to actually try and target this. So we're going to do a trial looking at a drug which targets interleukin 1 alpha called bermekimab, to see if it actually improves outcomes for people with cancer. Now, what we're seeing in this study particularly is that we are going to only give it to people who are inflamed. So we're only enrolling people who are inflamed, and then we're stratifying by inflammatory status. We want to make sure we've got equal numbers of inflammatory levels in each group, if you like, and also to look at inflammation and looking at the drug in the right type of people, not just everybody. So that's exciting, and that's happening in the next few months. So that's, I guess, what I would call targeted therapy for cancer cachexia. Interestingly, just for your interest, the Anna Morland story didn't really end there. What happened was that both the FDA, so that's the American regulators, and the EMA, that's the European regulators, they said, no, we're not giving this drug a license. But in Japan, they took a slightly different view, and they've actually approved Anamorelin. They accepted here that actually it made people with cancer gain weight. And they felt that if people with cancer gain weight, that's probably a good thing. I think patients certainly like to gain weight when they have cancer. We know that losing weight is bad. So I think, in these patients, they've gained weight, they're gaining some muscle. They thought that was a good thing. I think they were right. What they were saying here was that they actually, yes, it didn't improve function, but patients actually don't care about how strong they can squeeze their hand. What they can care about is, can they walk their dog? Can they play with their children, their grandchildren, whatever? That's what matters. So this is now actually approved in Japan, and I think the studies keep going on with Anamorelin, and I think what we're seeing here with the regulators here is a change of tact. It's not just about function. It's not just about lean mass. There are other things that are important. So just to sort of the last five minutes of the talk, I just thought I'd go through some of the regulatory aspects, because I think that's quite interesting for to understand how drugs potentially get to market. So the FDA, had a sort of a session recently when they were looking at some of the questions. And I've been at regulator meetings a few times, and what's quite clear to me is that they don't what they think matters to people is gaining muscle mass and gaining muscle function. I actually don't think that matters to people. What matters to people with cancer is their quality of life. Can they live well? Can they up in the morning, make their breakfast, have a shower, walk their dog, go to work? I think that's what matters is more. Now, muscle in some ways is an essential component of that, but I think a rethink is needed. So one of the things they're saying is, how important is this definition that was first defined? And it's a complex definition that probably lacks supporting evidence. It's not mechanistic in its basis. So, if you give somebody a drug for muscle, you should measure muscle. If you give somebody a drug for appetite, you should measure appetite. But in some ways, to give somebody a drug for appetite and hope that it makes them eat more and makes them gain more muscle is potentially a step too far. And they're coming around to a viewpoint, I guess, that quality of life is probably more meaningful in cachexia trials. They've also highlighted, I think, that there's been a lot of confusion in the field with cachexia, and then I think now accepting that actually it's inflammation is a critical component of that, and the learned guidelines have adopted that. In terms of should BMI and weight loss, how important are they? Well, they're important, but there are probably things that are more important. So performance status and inflammatory status are probably more important things for us to look at in clinical trials than simply weight loss. It's not just about loss of weight. Muscle's important too, and what this is data that we've just published. We've just published, and it's a cohort of 1,000 patients with operable colorectal cancer, and almost 650 patients with stage 4 lung cancer. Right, so a group of quite well people with colorectal cancer who are going to be cured, and a group of patients with advanced lung cancer. And we looked at muscle. What we showed, interestingly, was that myosinostosis, so that's how much fat you've got in your muscle, obesity, and sarcopenia were actually quite similar. So muscle didn't differ much between these groups. People who are well and are going to have a curative treatment for colorectal cancer versus those with stage 4 lung cancer, it wasn't that different. It wasn't that different. that inflammatory status was quite different between the two groups. Now, we are arguing here that essentially muscle is probably endemic. And I think if you look at yourself, how you are, how your composition is, how your body habitus is, I know I've not changed dramatically since I was about 22, and most people really don't change that much. So it may be that muscle's endemic, and trying to change that certainly requires a lot of thought and consideration and sensitive endpoints. Now, in terms of clinical trials, if we're going to measure muscle, which I think it's important we do, how are we going to do that? Well, hand grip strength, I've already said, is probably not a good measure. It's affected by age. There was another trial that was done, I've not mentioned it here, and it looked at a thing called stair climb test. So that's how quickly you take to climb 12 stairs. And that was another trial looking at another agent, which again was negative. But if you think of what affects your ability to climb a flight of stairs within a certain time, it can be affected by anemia. Well, a lot of our patients have anemia because it's pretty common in incurable cancer, or cardiovascular disease, or chronic obstructive airways disease, or osteoarthritis of the hip or the back. So we have to pick sensitive measures. What we are doing in a lot of our studies now is using what we call actigraphy. So that's patients monitored activity. And we use for that either a Fitbit, so one of the sort of bracelets you see right around the wrist, or we use sort of watches that people wear. But you have to be quite careful when you're using them in trials, because you can't give things that make people do more than they would normally do. You want a sort of an inert device. So interestingly, when we buy the Fitbits for our studies, or we buy sort of exercise monitors, we buy ones that don't do anything. They just sort of wear them almost like an electronic security tag. So should we include function in cachexia? Well, I think we should, but we need to use the right things. We will record step count, or because that really is as a surrogate of performance status. Drugs have failed because they didn't use the sensitive measures that potentially we could have used. So if we're going to move forward with getting drugs approved for cancer cachexia, we need to use the right population. We need to stage the host. We need to stratify based on inflammation. We need to use a pragmatic trial design where the trial fits with clinical practice, because that's where we want to be using these drugs in the future. We want to use sensitive endpoints, things that measure what we're actually trying to modify, and involve, engage the regulators through evidence, not belief, not what they think is the case, to actually what is the case. And clearly, the most important thing in all this is patient advocates. And I'm working with a group in the US, the Cancer Support Committee. They're a bit like Macmillan, they're a huge organisation, and they're actually lobbying the FDA to say this is what matters to patients for cachexia. Now, I've had several meetings with regulators all the time, and actually I was a bit unhappy. I thought, these people don't get it. They don't really understand cachexia. They think they do, they don't really do it. Then I realised actually it's not that they don't understand. We've not, as a cachexia research community, come together and try to get a house in order. And that's something that we're doing just now. I'm leading an initiative here where we are going to try and produce a sort of consensus statement for cachexia trials. So we're registered on Prospero, and what we're doing is we're analysing all the cachexia trials that have been done in the past 32 years, and we're doing 6 systematic reviews: body composition, nutritional intake, physical function, inflammatory intake, oncology endpoints, and quality of life. And we're sort of halfway through this process, and our aim is that by the end of the year, have a sort of consensus statement on endpoints in cancer cachexia clinical trials, which will make sure that when we're doing trials, we don't make the same mistakes again, and we're also using sensitive measures. As I say, with endpoints, it's time to get real here and measure things that matter and are sensitive. And a lot of our trials in Edinburgh are doing this and testing a lot of these endpoints out. These are our portfolio again of studies. So in terms of where we go now, well, I think we've progressed quite a lot. We're now sitting today with a drug license, not in the UK, not in Europe, not in the US, but somewhere in the world there's a licensed treatment for cancer cachexia. So from myself, as a palliative medicine consultant, Professor Stone, who's on the line, on the call, well, my colleague Dr. Spiller from Edinburgh is also on the call. We might one day soon have a drug that we can give our patients for cancer cachexia, and that's really encouraging. We're learning from the errors, and we need to do a sort of a good trial design. And I think we need to move with our approach. Cachexia is a complex phenomenon, and we can't just hit one blunt instrument for it. It might be that what we need to do with cachexia is think, well, what's going on here? Have they got a poor appetite? Let's give them an appetite stimulant. Have they got loss of muscle? We need something to build their muscle up. Do we target inflammation? Is that a key component too? So we have to take our precision medicine approach to this. We've got one vision here really, which is developing therapies for a condition which decimates quality of life. It decimates the quality of life of our patients and their families, and their caregivers. It impairs the delivery of systemic anti-cancer therapy. If I'm ever struggling to get oncologists to understand the importance of this, I tell them that this is one of the main factors which makes your treatment less effective. And it always shocks me here because none of us write on the death certificate, but it causes 50% of our cancer deaths. So it's a huge problem, but we are making progress. So I'm going to drop there. Thank you for your time and paying attention, and we'll have some questions now. And I'll stop sharing, I think.
Thank you so much, Barry. It was such a really interesting presentation. I think, as Bella highlighted, it's all a sort of cautionary tale of study design and really thinking about the outcomes. So I think before we move on to questions, I'd like to invite everyone to show themselves, sort of reveal themselves and unmute, and give Barry a round of applause for the presentation.
Thank you very much.
Nice to see people.
Exactly. I think it's always nice to see that people are actually listening and people are there and taking it all in. So if we move on to the questions, as I said before, if you've got any that you want to write in the chat box, go ahead. If you'd rather ask your question, raise your hands. Paddy, I see you have written a question. Would you like to ask that yourself?
Sure. Hi, Barry. Just thanks so much. Great to have you here. And I'm sorry for our sake. It's virtual, but it did mean we had a very good turnout, which is excellent.
Oh, it's great. Absolutely.
So obviously you talk an awful lot there about inflammation, and you did talk about non-steroidal anti-inflammatory drugs. In palliative care, there's been one study, hasn't there, looking at steroids for fatigue, dexamethasone use for fatigue, and it does work for fatigue, but we're always reluctant to use steroids. But steroids are anti-inflammatory. Is there any role for steroids in this situation?
So, I think so. I think short answer, yes. I mean, what I always sort of regard, so dexamethasone probably is what I most commonly use. Paddy, I'm sure maybe you're the same. It can have quite good effects initially, as you're aware, on making people feel better, make them feel generally more energy, and helping their appetite. But what I always feel with steroids is that there is a role, but they're a bit of a crude instrument, because after a short period of time, they cause quite marked sarcopenia, loss of muscle, and particularly proximal myopathy. So they have a short-term effect, but then they can have quite a lot of side effects. So I think that if we can potentially get better steroids, or if you like safer steroids even, then they could have more of a role. In some ways, what we're trying to do with some of the more potent anti-inflammatories, like the IL-1 drug, for example, it's just a stronger anti-inflammatory with potentially less side effects. So what I say is we can use them, but we should use them in short. I always say short, sharp shocks. A reasonable dose for a short period of time, then stop it. And one of my pet hates when I do my rounds in the hospice is I see people on 2 milligrams of steroids that they've been on or dexamethasone they've been on forever. I think why no one even remembers why it was started. Do you know what I mean? I'm sure you're the same. So I think there is a place, but caution is advised. I would say caution is advised with steroids.
Yeah, thank you. Thanks, Barry.
Perfect. We have a question from Joe Brady, who has said, is there any concerns about side effects or risks, risk profile of anti-inflammatories, e.g. GI, cardiac?
Yeah, good question. So when we did I mentioned our Premenop trial there. So that was a trial where we give an anti-inflammatory alongside exercise and nutrition. In that study we used celecoxib, okay, and it was quite a challenge. We did that trial in Glasgow when I worked there, and it was quite a challenge trying to find a patient in Glasgow with lung cancer who didn't have some form of cardiac disease, and of which celecoxib is a no-no, right? It's a no-no. So you know, because it's quite a lot of bad effects. So essentially, when we went to our phase 3 trial, we used ibuprofen. They do have side effects. Ibuprofen, however, is relatively safe, and we did give people omeprazole or PPIs alongside it if they needed it. But generally, it was pretty well tolerated. I always find it funny when the oncologists say, you know, oh, the ibuprofen's knackering their kidneys, and I say, well, actually, you sure it's not that really toxic chemotherapy you're giving them that could be doing that? You know? So I think that what we can't say at the moment is give all your patients who you think have got cachexia or are developing cachexia an anti-inflammatory. We can't say that. The trial may say that it's helpful, and that, you know, that's going to hopefully be published by the end of the year.
Perfect. There is a question from Jane Bond that says, can I ask you to explain more RE, the 50% cancer deaths caused by cachexia?
Yeah, so that's interesting. That's interesting, Jane. So I'm like, you know, it's one of these things. If you read any cachexia paper, it says that within the first paragraph, it says cancer cachexia results in about 50% of cancer deaths. Okay, nobody's done a large study to try and assess that. Now, I know from doing this talk in Edinburgh and in Glasgow, none of us have ever written. I've never written on a death certificate cause of death 1 cancer cachexia. We don't write it. So it's difficult then to see how many people die of it. But we've done retrospective studies in lung cancer, pancreatic cancer, colorectal cancer, which I guess are relatively, you know, have biases, suggesting it's up to about 50% of cancer patients. But, you know, if you were to look at people near the end of life, what they look like, a lot of these people would look like they had cachexia, profound muscle loss, not eating very much, loss of weight. So, you know, I would love somebody to do a study where they actually try to determine the accurate prevalence of cancer cachexia death. Because Paddy will correct me here, but I don't think that's been done, and it'd be interesting to see, you know, what the actual cause of that is.
So there is another question from Juliet. I can actually see Juliet's video, so I wasn't sure if she wanted to ask the question herself. Yeah, go for it.
Thanks. Yeah, no, it was just I was just curious if I know there's been a huge amount of well, there is currently a huge amount of interest in the role of the gut microbiome, and you know, Tim Spector obviously has been doing amazing things through his app, which then linked with the COVID study. And I just want, you know, is there any indication at all that tailoring nutrition for patients with advanced cancer makes any impact, you know, relating to the gut microbiome? It's just, you know, we're always saying to patients, oh, it really doesn't, you know, if you don't feel like eating, don't worry, it doesn't matter at all what you eat. Or, and I just, you know, does it? Is there any?
Yeah, that's an excellent question. I would argue, I would just make it clear here, a disclaimer, Juliet and I are close colleagues, but we have not planted this question. No, so that's interesting, Juliet. What happened was that we put in a big cachexia grant last year. We weren't successful, and in that grant, we had a guy called Phil Quirk who's in Leeds. So he's like one of the world microbiome experts. And he said to me, Barry, I cannot believe it, in all this time researching cachexias, nobody's looked at the microbiome, because you think one of the problems here is inadequate nutrition, and no one's actually looked what's going on in the gut. So the answer at the moment is we don't know, but we're testing it out just now. So we're collecting stool samples from people to see if there's some potential changes in the gut microbiome that could be causing cachexia. My hunch is that it is, but we're looking at that just now.
Fantastic, great.
So yeah, it's really, there's been there's a grant called the Opportunistic Grant going on, a big sort of Cancer Research UK funded study looking at colorectal cancer and the role of the microbiome, and they're producing staggering results saying that the microbiome is something that's really important, has been hugely overlooked.
Yeah. Thank you.
Thank you, Juliet. On a related note, Eleni, I'm sorry if I've said that name wrong, has also asked about, until we get research data, what kind of diet should we be advising our patients to follow? There's lots of studies that show the anti-inflammatory properties of various foods, spices, herbs, etc., and the pro-inflammatory nature of many foods, such as processed foods, etc.
Yeah, that's a really good question. I was doing a podcast last week about cachexia, and it was for B-told oncology, the lung oncology people, and that was one of the questions they asked me. And they said, "Oh, we don't have time in our clinics to give people nutritional advice." And I thought, I find that hard to. I didn't believe that. I think that's not the case. So what I would say is that it's important people take. So I'll start again. We don't yet have strong trial evidence that this will be helpful. We hope to have. We've got some good sort of preliminary data, and we think that altering their diet can help. Okay, but what I'll tell you what I say to my patients: move away from having sort of 3 meals a day. That concept of 3 meals a day, you know, it's quite difficult for people to eat that way. You know, the hospice where I work part-time, until 2 years ago, patients dying with advanced cancer got a full English breakfast if they wanted it, a 3-course lunch, and then a dinner. And I thought, I couldn't eat what they're trying to eat in a day, never mind, you know, what we're trying to give them. So what I say to people is, it's about getting in energy, and I use that term energy, it's a positive term. And so small meals, little and often, and energy dense meals. So high calorie foods and high protein foods are key to this, I think. And having small meals often, and the caregivers are often the people who find cachexia really stressful, because they'll try to make nice food for their loved one, and they're disappointed when they don't eat it. And I sort of can use them as a sort of foot soldier in this by saying, right, what, you know, does your husband or wife, what do they like? Well, they love they like scones, or they like tray bakes, or they often like custard. I say, well, this is what I want you to do, is make these high energy foods, and that's key. In terms of anti-inflammatory properties, well, we know that things that are high in omega-3, oily fish, etc., we know that they're anti-inflammatory. In one of our trials, we give a nutritional supplement that's got high levels of omega-3 in it. So I also say, if you want to take some omega-3 as well, you could do that. But a highlight caution is that a lot of this is not evidence-based as yet, but I don't think it will do any harm. And it certainly makes food more palatable if they have small amounts of food, little and often.
That's great. Thank you, Barry. So I think we've come to an end. There's no more hands up and there's no more questions in the chat box. So I just want to take this opportunity again to say thank you. Thank you for taking the time to give the presentation. I think we've got a few claps and for your time. Everyone's saying thank you.
That's super.
Thank you. Thank you.
And so I'd just like to wind up by saying that we'll have another seminar in the future, and we'll send out the information when it's available. But thank you all very much for taking the time out tonight to join us.
Thank you.
Thanks.
Thank you very much.
Thanks so much, Barry.
Thanks,
Great to see
Barry.
and hear you.
Thank you.
Very
Bye.
entertaining.
Thank you.
Take care.
a lot.
Very good.
Thank you.
Cheerio. Bye-bye.
Thank you. Bye.